All right, to try to stay on schedule, we'll go ahead and get the next speaker. Really like to thank Mahshid for being able to speak today remotely. I know she's really busy, and have her come and talk about her EPOC study is going to be terrific. So I'd like to welcome Dr. Mahshid Abir on screen. Dr. Abir is a senior physician policy researcher at the RAND Corporation. She's also an emergency physician and director of the acute care research unit at the University of Michigan. She will discuss her findings from the EPOC study, which really identifies best practices to increase out-of-hospital cardiac arrest from kind of what Dr. Newmeyer was talking about, a systems of a care perspective. So, Dr. Abir, if you want to make sure you're off mute, and you can go ahead and share your screen.
Excellent. Well, hello everyone. Good morning. I'm really pleased to be here, and I appreciate the opportunity to present the final products from the 5-year Enhancing Pre-Hospital Outcomes for Cardiac Arrest, or the EPOC study, with everyone today. So this study was funded by the National Heart, Lung, and Blood Institute, and I think that this first slide is some content that you all have already heard from a couple of speakers today. Essentially, you know, as you all know, the inpatient side of cardiac arrest and addressing it, cardiac arrest for successful response in the inpatient setting has been studied pretty extensively. And one example of studies that have looked at that is the HEROIC study, which is also NHLBI funded, and my co-PI in the EPOC study, Dr. Brahmanji Nalamathu, who is a cardiologist at the University of Michigan, is also a PI on that project. However, on the pre-hospital side, particularly evaluation of strategies for responding to cardiac arrest and increasing survival from a system of care standpoint are kind of limited. So what we did in the EPOC study is that we took some principles and methodologies from the HEROIC study that looked at multidisciplinary response to cardiac arrest in the inpatient setting, and also took our learnings and methodologies from other RAND studies that looked at multidisciplinary and multi-stakeholder response in the pre-hospital setting by first responders in order to design the EPOC project, and ultimately try to understand how we can improve ACA survival from a system of care standpoint. And, you know, I think that the concept behind this particular figure is going to be familiar to many people in this audience. So ultimately, responding to cardiac arrest in the pre-hospital setting involves a number of stakeholders. So ultimately, public safety. So obviously, that includes fire, EMS, police. And healthcare, which is the hospitals as well, public health. And it is really, you know, understanding the magic sauce of response and successful strategies, where all these different stakeholders come together, that ultimately we were trying to get at through this EPOC study. And, you know, some of these statistics many will be familiar with, and I mean, this predates the pandemic, this particular statistic, but Michigan, again, not unique in the United States in the kind of variation that we see in communities for cardiac arrest survival. As you heard Bob Newmeyer say earlier, it really shouldn't matter, or where you arrest should not be dictating whether you survive or not. So what we really want to understand is that all else being equal, what are some of the factors in localities on the response side involving the various responding entities for cardiac arrest that makes a difference, and that is the difference that we're trying to capture, and we want to identify and benchmark those best practices so that we create an equal playing field as far as survival is concerned. So one of the things that is different about the EPOC project is our choice of the primary outcome of the study. So, deliberately, the outcome that we chose in our study is sustained loss with pulse upon ED arrival. And you all know in this audience that the resuscitation world, the outcomes that are considered are usually, did you survive to admission to the hospital? Did you survive to discharge? Did you survive with good neurological outcome to discharge? And what we wanted to do is really capture the part, and meaning the outcome, that really can be most closely tied to the role of the pre-hospital stakeholders, namely dispatch, police, non-transport fire, and EMS. So basically, how can we pick an outcome that really captures everything that happens before a cardiac arrest victim gets to the emergency department? So that dictated our choice of primary outcome. So this 5-year NHLBI study was conducted in 3 phases, ultimately with the objective of identifying best practices to increase out-of-hospital cardiac survival from a system of care perspective. So in phase 1, we sought to understand variation in cardiac arrest survival based on that outcome among EMS agencies in Michigan. Once we identified that variation, we sampled from across the variation in outcome that we identified, and we did site visits to a number of emergency medical systems in Michigan in order to identify best practices for a system of care response to cardiac arrest by conducting interviews and focus groups. And ultimately, in phase 3, we sought to validate the best practices that we identified in phase 2 for survival through a statewide survey. And ultimately, the last goal of phase 3 and the final part of the project is to disseminate the EPOC toolkit, which is really ultimately identifying strategies for increasing survival from cardiac arrest and learnings from the whole project. So really quickly, I'm going to go through just very brief methodology and findings from phase 1 and 2 because these findings, either me or my colleagues have presented in prior SaveMIHeart meetings and other meetings through the Michigan Department of Health and Human Services. So many may be familiar with these, but for completeness and so to tell the whole story of this project, I'll briefly review each of the phases. So as I mentioned, so in phase 1, with the goal of really kind of assessing the variation in the state of Michigan, we analyzed MyCare's data from the years 2014 to 2017 to identify variation in the primary outcome of interest. And we found, no surprise to anyone here, wide variation rate of sustained loss with pulse upon ED arrival with a mean of 25.3, and you have the range there. So the range is astronomical. And essentially, we identified the range to identify high-performing and low-performing cardiac arrest survival agencies, so that then we can sample from across those so that we visit both high-performing and low-performing agencies to understand their practices around cardiac arrest response. Among the 7 high-performing cardiac arrest survival agencies that we identified, mean loss with pulse upon ED arrival was about 40%, and among the 7 low-performing cardiac arrest survival agencies, mean loss with pulse upon ED arrival was about 10.8%. And these 14 that we identified, ultimately, we sampled 9 out of these 14 with the goal of making sure that the EMS systems that we're visiting are regionally representative from the different trauma regions of the state, also include those that are in urban centers, suburban, and rural, so that we really kind of understand also the role of location and urbanicity on some of these response issues that we are probing. This essentially, I put this here because it really impressively, in a graphical way, demonstrates, again, the variation that we saw. On the y-axis here, you have the probability of ROSC with pulse upon ED arrival. And each of those bars that you see there through the x-axis is an EMS agency. And essentially, this figure represents patient standardized probability of ROSC with pulse upon ED arrival across 91 EMS agencies, covering more than 6.8 million lives. So, and this is the phase 2 part that we really enjoyed. And if anyone in this audience was part of these site visits and talked to us, I just want to send another big thank you, because everything that we learned was really critical ultimately to the development of the toolkit that I'll be sharing with you today. So as I mentioned earlier, we conducted interviews and focus groups in 9 communities across Michigan. These EMS systems included dispatch, call takers, EMS, police, non-transport, fire, and emergency department, and again included urban, suburban, and rural settings. So, you know, for the interviews, we conducted interviews with both leadership in these organizations that we visited, and also some supervisors and folks responding, you know, technicians and EMTs and other providers. And the focus groups were multidisciplinary. So there was folks sitting around the table across all these stakeholders. And the interesting part was that in 2 of our visits, that the folks who were actually in the focus group, either the same day or the day before, had responded to a cardiac arrest event. And some of them were there. A few people from the group were the same people who were on the field, and it really allowed us to probe these issues related to multidisciplinary response and handoffs between the various entities, and how well people work together in real time based on a very recent event, which was, you know, highly informative. So we had a lot of findings from these phase 2 interviews. Our interviews and focus groups involved about 120 different individuals. And what I'm sharing here under key findings is really just a sample of some of the findings and strategies that we identified, of many. So the first one is understanding the importance of multidisciplinary training and debriefing. And interestingly, one of the commonalities that these high-performing sites and EMS systems had was either very close informal relationships between the key stakeholders, so police, non-transport, fire, EMS, hospitals, or actually formalized relationships where they did multidisciplinary training and or debriefing. And that seemed to be something that the EMS systems that we visited that didn't have as high survival rates didn't do. Another important finding in the high-performing locations were the continuous quality improvement efforts. So a lot of the places that had high survival rates had processes in place that would continuously at least review the very difficult cases of cardiac arrest response. In some places, it was all of them, and obviously the places that are able to do that kind of quality improvement effort, they're resourceful and oftentimes have resources to do it. And conversely, the places that had lower cardiac arrest survival didn't have as extensive of such approaches in place, and oftentimes that was also related to lack of resources. So another thing that we heard is that consistently in the places that were the high performers, there was the name of an individual or 2 individuals that the place highlighted as critical to their success. And these are the folks we call the pre-hospital care champions. So oftentimes this can be med control, or it can be, you know, someone in one of the responding organizations, or, you know, maybe an emergency physician, or in the emergency department that's part of that emergency medical system. But these folks make it their business to understand and share best practices and evidence-based practice among the first responders. So they seem to be critical. And some of the places that didn't do as well cited the need for such individuals, and even whether such individuals could be shared among localities so that people can benefit from the learnings that can come from being associated with someone who's proactive in this way. Dispatch-assisted CPR was another practice that the high-performing sites conducted. Again, this requires resources and financial investment, and not all places are able to do it, and that was one of the issues that came up. And information sharing of best practices, so being able to, among different stakeholder groups and within stakeholder groups, sharing best practices that are gathered from frontline response and basically operational activities, so that everyone can learn from them, and even there can be an exchange of folks' experiences or varied experiences potentially with these best practices. And obviously hands-only CPR, and I don't need to kind of talk about the value of that among this crowd. So now I'm going to transition to the part of the study and findings that are new, and that this is the first time that we're sharing these findings. Some of them have not been finalized, so I want to share the findings with some caveats of particularly the details of the analysis that I'll be sharing in the following slides are not final, so they're somewhat of a work in progress, but I do want to share some of that with you all. So, as I mentioned in the beginning, we wanted to validate these strategies that we learned from these qualitative interviews and focus groups. We want to see, is there any way of assessing whether they actually help improve outcomes? How can you connect what people are saying works with actual numbers and survival? So in order to do that, we conducted an analysis of a statewide survey of Michigan transporting agencies. So a survey that was disseminated to all transporting agencies in Michigan, which included 222 CARES participating agencies. The survey included questions about potential best practices that we identified in the site visits. And we wanted to assess their validity through an electronic survey that we primarily administered. The target people for this survey were the EMS agency administrators, although as you will see, there were other folks who also served as the respondent. We had a total of 60 questions to capture information about ACA procedures, policies, and perceptions, and about kind of relationships and involvement of various stakeholders in ACA response. We had the survey open for about 150 days between October 2020 and March 2021. And for the 222 agencies that were CARES participating, we linked their responses to their own outcomes in the CARES data. With the primary outcome being, as I mentioned before, sustained loss with pulse upon ED arrival, and a number of secondary outcomes, which are listed here. So although we surveyed all, the goal was to survey all transporting agencies, the analyses that I'm about to report and the results that I'm reporting here are really in response to, regarding the responses from the CARES participating agencies. So once we got the survey results back and we linked those results to the agency's own CARES data, we conducted a multi-level logistic regression model. We did an unadjusted and adjusted model. In the unadjusted model, we had fixed effect for each question and random intercept for transport agency. And in the adjusted model, we adjusted for a number of factors which you will all be familiar. So covariates across 3 domains. So patient factors like age, race, gender, community factors, for example, education level, and then arrest factors like location type, witness versus not, and rhythm type. So, and the output of this analysis was unadjusted and adjusted odds ratios for performance on each outcome by each survey response. And the p-value that we used to consider statistical significance was less than 0.05. So we had an impressive response rate of 71.1%. And of the respondents, basically, you will see who were the actual responding entities who responded to this survey, with the majority being director or chief, followed by QA manager or staff, field supervisor, etc. And there were some field staff who also responded, and then a few medical directors. But the vast majority of respondents were director or chief role. And as far as the agencies, who are these agencies, some characteristics of the agencies and their call volume. So the majority were kind of non-fire, state, local government, followed by fire-based, followed by private, nonprofit, private, and in some instances, people didn't answer this question, so those responses were missing. And as far as call volume, you'll see, I mean, some of these respondents have really kind of many annual ACA events. Others had fewer, and there were some instances where people didn't respond to that question. So of all these questions that we asked folks about essentially the strategies that they use to respond to cardiac arrest events from a system of care standpoint, there were three strategies that were statistically significant, both in the adjusted and unadjusted models. So for today's talk, I'm going to only present those three, and in the interest of time. So the first strategy that was that showed statistical significance in both models was unseen use of modern clinical equipment in an effective and appropriate way. So an example of a modern equipment is a rescue pod, or it can be other devices that are used in cardiac arrest response. And the question really was worded, does your EMS agency use it? For example, there were various questions on different types of equipment, and one of them is impedance threshold device. So in this case, about 83%, close to 84%, don't use those. Over 16% do. And ultimately, what we're presenting here, the difference between those who did use compared to didn't use the impedance device, the raw risk difference was 3.97%. This ultimately translates to a striking 44% improved odds of ROSC with pulse upon ED arrival. So, and yes, it's a very striking and impressive improvement. But there is other research that has shown the effectiveness of such devices in improving cardiac arrest outcomes. The second statistically significant strategy that again showed statistical significance for both the adjusted and unadjusted model is a debriefing. So conducting a multidisciplinary debriefing after cardiac arrest event. The specific question that was asked of respondent was, how often does a formal debrief with crews occur following a cardiac arrest event? So, and the response options were less than 5%, 5 to 49%, 50 to 95%, or greater than 95%. So the findings here show a significant improvement in cardiac arrest response among those who do use multidisciplinary debriefing. And essentially the debriefing translates to about a 9.4% improvement in a ROSC with pulse upon ED arrival. So last but not least, the third strategy that again was statistically significant for both models was ensuring that all responder groups get feedback on ACA performance and outcomes, so that, again, if you have a multidisciplinary response to an ACA event and you have police there, you have non-transport fire there, you have EMS there, to put mechanisms in place so that everyone on the responding team, get some feedback on what happened to the patient and what were the outcomes, what was the performance. And the specific question that we asked folks was, how often does your EMS agency share reports on cardiac arrest response performance to EMS crews? So 38.24% don't circulate. Then you have people who do it on a monthly or more, and that is over 16%. Quarterly is about 6%. Annually is about 12%, and other is about almost 28% of respondents. What these data show is that circulating outcomes and essentially reports on performance and outcomes to crew is associated with a almost 4.7% improvement in ROSC with pulse upon ED arrival. So, there is a tremendous more analysis around all the survey items that were circulated in this analysis. The ultimate goal, as I mentioned at the end of phase 3 for this project, is development of the EPOC toolkit that essentially aims to really outline all the strategies that we've learned about in all the phases of the work. So that ultimately, we can provide a toolkit of recommendations for EMS system providers and champions, leveraging our data in order to help improve outcomes and really kind of, again, make it so that it doesn't matter where you are when you arrest and that you have an equal likelihood of survival. The recommendations in the toolkit are organized at the incident level, stakeholder level, and system level. And this figure essentially, I'm going to talk through this here a little bit. Essentially, we've identified the different phases of the response. So activation, pre-arrival, early professional response, full resuscitation team, transport and handoff to the hospital. So essentially, one level of strategies are basically introduced in the toolkit by the phase of the incident. Another level is at the stakeholder level. So the various stakeholders that are involved in response that make up the emergency response system. Ultimately, we have recommendations that are parsed out in the toolkit at the level of the stakeholder as well. And also, so ultimately, yes, so apologies, this is. So in the next few slides, I'm going to go through, as I mentioned, these different recommendations by level of recommendation. So there is a number of recommendations at the incident level. So under pre-arrival, one recommendation is to develop processes for dispatch providing updates to responding units as additional information becomes available, so that this communication, there are processes, well-developed processes and implemented processes in place to allow for continued communication of information as the incident is unfolding. On scene, use modern clinical equipment effectively and appropriately. So the effectively and appropriately part is based on information in the toolkit that is included based on a literature review, showing that it is not enough, obviously, for a crew to have all the tools, the latest technology, but also to get training in so that the staff can actually use those technologies effectively. Under transport, essentially transporting providers may use ventilators or mechanical CPR devices to offset space and staff limitations in the case of mechanical CPR. So that if you do have a mechanical CPR device, you may not need as many staff in your response. And handoff has to be structured in an efficient and standardized way. So this is both among the stakeholders in the field and also from handoff of the pre-hospital providers to the emergency department staff. And ultimately, a debrief needs to be conducted after cardiac arrest ideally after every event and after and in a multi-stakeholder fashion. And the asterisks here represent the findings or recommendations that were validated through the analyses and survey that I just presented. Under stakeholder level, we have community recommendations to basically educate the community around cardiac arrest recognition, performing CPR and AD application, and I think that the two parts of this that really stand out is the recognition of cardiac arrest that both bystanders and at times 911 call takers or dispatch have challenges with, and AD application, which not everyone is comfortable applying as far as the community and bystanders are concerned. And as far as public safety is concerned, create a standardized training program for each stakeholder tailored to their specific role in the field, and consider cross-training responders in multiple roles so that people not only train among their own peers, but also across stakeholder groups, so including training police and non-transport fire and EMS in the same setting. So at the system level, relationships seem to be critical, and the recommendation is to maximize the frequency of crew interactions in both emergency and non-emergency settings so that they develop essentially both formal and informal relationships that will help in more effectively and successfully responding to cardiac arrest incidents. And establish a culture of open communication among institutional stakeholders. This is critical because without a bidirectional open communication, you can't really improve systems. And collaborative training opportunities, again, so that multiple stakeholders are involved concurrently during the training processes, and ensure that the equipment used across responder groups is compatible, so that people are familiar with the same types of equipment ideally, so that things can go more smoothly during incidents on the scene. And also ensure that all responder groups get feedback on ACA performance and outcomes. And again, this was another outcome that was validated through the survey that we disseminated. And last but not least, the recommendations in change management, so that if you are, and the readers of the EPOC toolkits and champions are looking for effecting change, you need to understand that red tape, financial barriers, and incentives stakeholders must navigate to be successful. You need to include everyone, and by everyone here we mean all stakeholders at the community level, again at the responder specific organizational level, so that everyone has input into change in systems to be more successful in survival. And implement change in phases. So, you can't do change overnight. You can't implement system levels change overnight to improve cardiac arrest survival. This has to happen in phases. And you really do need to run trial periods to gather feedback from the folks who, the change affects, so that you can really respond to their input so that you're optimally implementing the change and are successful. So lastly here, last slide, the EPOC toolkit will be presented as is going to be a RAND report. It's going to be a free online source, and it's expected to be published in July of 2022. We will broadly disseminate this through RAND, its national and international network, but we'll also aim to disseminate it through key state and national organizations. We do have a potential follow-on project to implement and trial the EPOC toolkit strategies, particularly those that have shown promise through our survey validation process. Thank you very much.
So really taking that variability that we saw, in the data section, and kind of diving deep in understanding what we can do about that, right? So having pre-hospital champions, getting our data into cares and understanding how that's going to impact outcomes, and debriefing, understanding what we did right, what we did wrong, and sharing those things across the systems. So are there any questions for Dr. Abir? There's one question in the back. Hold on, Bob, I'll get you a microphone here. So Mahshid can hear you.
Hi, Mahshid. Nice talk. Thanks very much.
Hello, thank you. Good to hear your voice.
Good to be seen. You outlined a fairly comprehensive approach. Where's the lowest hanging fruit? Where do you think we can make the most impact?
So the ones that stand out to me are continuous quality improvement and debriefing. So I think that the multidisciplinary debriefing would have been less promising before the pandemic when people were not using online platforms for communication as we do now with Teams or Zoom, etc. So I think that the environment is different. People are a lot more comfortable and willing to just get on a call, whereas getting everyone in the same room previously would have been very challenging. So I think that's a particular low-hanging fruit, and the one that doesn't involve as much or any potentially funding or financial resources. I think others are not heavy lifts necessarily. So, having tele-CPR or continuous quality improvement, you can do it in gradation, you can do it in phases. And I think ultimately those would need financial resources. So those are heavier lifts. But at the end of the day, I think the ones that involve multi-stakeholder involvement, whether it is at the front end when you're training or that when you're debriefing, have the highest promise because, again, they're not tied to huge financial investments.
And then what did the champions look like? Who were the champions?
Well, you're one of them.
Thanks.
True story. So, these are individuals, in a nutshell, to describe a champion is someone who is interested, who is passionate, who is dedicated to cause of EMS more broadly, not just cardiac arrest. Are not always physicians, although they can be physicians, and the physicians that are either they're the med control or MCA directors, or emergency physicians who are trained in EMS, who've done an EMS fellowship. But mostly I think that the key ingredient for those individuals are the first ingredients that I mentioned, the interest. The interest usually leads to knowledge, and these individuals spend the time to learn about evidence-based practices, current evidence-based practices, and also to disseminate them. They're limited at the end of the day. They're very particular individuals. There aren't enough of them to go around. And I think the idea of somehow sharing these individuals among regions so that people who don't have them in their communities can benefit from them is a thought. And the other part is that is it something that we can formally incorporate, for example, in EMS fellowship trainings, the making of a champion, or identify them early and incorporate. You would have to develop an educational and training process for this, but so that it is more purposeful in their fellowship training, how to become a champion for your community.
One last quick question, Bob.
Dr. Abir, it's Bob Newmar. Great presentation, great work. I wanted to highlight one of the statistical findings you found and ask a little bit more detail related to the reporting back to stakeholders of the data. We've had a great investment here in the state in getting CARES data into the system. We report it here on an annual basis. But can you give us a little bit more detail about your recommendations of how that data should be disseminated locally in terms of how far down, all the way down to individual providers? Because right now I think it goes to sort of EMS directors and hospital directors, but doesn't often go any further. And in your data, do you understand how far down it should go all the way to individual providers? Is that what the recommendation is?
Absolutely. And in fact, this is a finding in our site visit that almost uniformly boots on the ground were asking for. The issue was that we only hear about the things that don't go well. We only get the feedback the person died. We never hear about the good stories, the survival stories. So, and you know, sometimes they call the hospitals to even get this information. So I think that it's definitely that link between whoever in leadership is getting these data, whether at the hospital level or at the agency level, they need to give that data back to the people who are involved. And in fact, this request wasn't just paramedics and EMTs, it was also police officers who want to know. You know, the ones that were involved in putting the AED on there because they got there first or they were first on the chest. So having processes to get it all the way to the boots on the ground, I think would be really, really important, because I think it, especially for the success stories, it helps with morale. And I think that it is just as important to learn from the cases that didn't go well than it is to learn from the ones that did.
Thank you so much, Dr. Abir. That was a great presentation, great conversation. So thank you so much for your time, and it's good to see you.
Thank you. Appreciate it. Have a great day.